IVF. It gives me great pleasure to welcome you all to today's clinical round on menstrual cycle and assisted reproductive technology. So, we all know the menstrual cycle is the basis of fertility, and a clear understanding of its phases helps us time and tailor ART procedures more effectively. So, today's discussion will be connecting those basics with their practical application in fertility practice. We are privileged to have with us our speaker, Dr. Sheetal Jindal, an accomplished fertility specialist at Jindal IVF with a strong focus on ART, clinical practice, and patient centered care. And we are equally honored to have our expert, Dr. Umesh Jindal ma'am, who is pioneer in reproductive medicine, founder of Jindal IVF, and a passionate teacher who has wholeheartedly trained and mentored many doctors over the years, shaping the practice of fertility care. So I now invite Dr. Sheetal Jindal to begin the session.
Yeah, thank you, Sonal, for this kind introduction. So the topic given to me was menstrual cycle and ART. So preparing this topic, I realized I must thank Dr. Umesh Jindal for giving me this opportunity to touch back to my basics again. And each time we read the menstrual cycle, each time we pick up the ART books for basics, I think it just tells us how much less we know and how much more there is to know. So anyways, so by the end of this presentation, I think I should be able to tell you, you should get well versed with physiology of ovulation, the concept of FSH threshold and window, and what are the various hormonal changes which occur in the menstrual cycle. I will just show the protocols in ART and how LH surge is prevented, the trigger concepts which are there. If we want to take a fresh transfer, what are the challenges with current ART techniques, what is split cycle ART, and what are random start protocols. So I think the first slide is a very busy slide, but just to start, we all have to be very well versed with the physiology of ovulation. So we all know that following the demise of the corpus luteum, there is a fall in the estrogen and the progesterone hormonal levels, and this marks the beginning of menses. And from the beginning of menses, it is called as day one of the menstrual cycle, from which we enter the early follicular phase. And during this early follicular phase, both the estrogen and the progesterone levels, they fall. And it is during this time that inhibin A levels also fall, which lead to the increased gonadotropin GnRH pulse frequency and leads to the rise in FSH levels. Now the antral follicles which we see at the beginning of the menstrual cycle are usually 2 to 10 in number, and these antral follicles under the influence of FSH grow in size, and which marks the early follicular phase. And after that, the FSH levels they fall, and but there is induction of LH receptors on the growing follicles, which leads to the with the induction of LH receptors, we enter the late follicular phase, and then subsequently with further growth of the follicle, we reach the ovulation. Now, now this is just in bit that what I want to say is that we have an early follicular phase and a late follicular phase, which is followed by ovulation. I will touch back upon this in greater detail in the subsequent slides. Now, at the beginning of if we talk of human ovary, in the human ovary, there are, in utero, if we see the primordial follicles or the germ cells, they are seen in the human ovary as early as 6 to 7 weeks of gestation, and they continue to grow by mitosis, and at around 16 to 20 weeks, there are approximately 500,000 oocytes, and at birth there are approximately 300 oocytes. Now these oocytes, are called as primordial follicles, and these primordial follicles, they are till the growth of the antral follicles, which we see on ultrasound. These are gonadotropin independent growth of the primordial follicles. Now, how much time it takes for the primordial follicle to grow to primary follicle is not very clear in the human in humans. But usually the growth of the primordial follicle to the antral follicle takes approximately a year. And these primordial follicles, they get surrounded by granulosa cells, and subsequently, before they reach the antral follicle at the pre-antral stage, they start developing the theca cells also from the surrounding stromal tissue. Now, these follicles, pre-antral follicles, are the ones. From there onwards, there is what you call as they become receptive to the hormones, that is the FSH, which is called as gonadotropin dependent stimulation. Now, the initial primordial follicles, out of once they are, now this is called as primary recruitment, that few of the primordial follicles, this cohort of follicles, they get activated and they are propelled to develop up to pre-antral stage, which is independent of gonadotropin recruitment. And that is what hallmarks hallmarks the initial recruitment. Now, this initial recruitment is very important because it's only the pre-antral follicles and the antral follicles which we are interested in as far as IVF is concerned. Now, what happens is these till puberty, these pre-antral follicles, because they do not get any FSH stimulation, there is no HPO axis activation, they undergo atresia. Now, once the female girl reaches its puberty, these follicles, this cohort of follicles which are initially recruited, they, under the influence of FSH, they begin to grow. Now, these antral follicles, now this is called a secondary recruitment. And this secondary recruitment is something which is, if we do a day 2 scan, these are the follicles, these antral follicles are seen in the early follicular phase of the menstrual cycle. If we are doing a scan on day 2, the recruitment which happens, this secondary recruitment is usually 2 to 10 per ovary. And these antral follicles are the ones which are of interest to us. And then out of them, under the influence of FSH, the follicles will grow, and the follicle with the maximum FSH receptors, because that is the one FSH receptors on the follicles helps in the production of estrogen, and the follicle with the maximum LH receptors undergoes further selection and achieves dominance, which is usually seen on around day 5 scan if we are doing in a natural cycle. And this dominant follicle further, as we see further, is the one which is destined to become the follicle which will ovulate further and probably give us a pregnancy. Now, I just want to tell you the concept of FSH threshold and FSH window. Now, what happens is usually if we talk of the cohort of follicles which we usually see on day 2 scan, now this cohort of follicles, if we see the menstrual cycle in detail, there is a rise in FSH up to initial day 5 of the menstrual cycle, and this rise in the FSH is the one which propels the follicle to grow to a certain level. And after that, the FSH, because these follicles have FSH receptors, now once the follicle has achieved an approximately 7 to 8 millimeters in the normal menstrual cycle, there is secretion of estrogen by this follicle, and this estrogen exerts a negative feedback loop on the hypothalamus and pituitary, causing the FSH to fall. Now, once this FSH level falls, most of the other follicles will undergo atresia. It's only the follicle which has the maximum number of FSH receptors, it will continue to grow. Now, what this FSH threshold is, it is this minimum level of FSH which is required for this continuing follicular growth beyond antral stage. And this is very, very important in the normal human physiology. This FSH threshold is achieved by only one of the follicles that is destined to ovulate. Now, in ART, we use this concept of FSH threshold. Now, the cohort of follicles which is getting recruited in the beginning, which we see on day 2 scan, if we give some exogenous gonadotropins during this FSH to a certain level, now this FSH supply by exogenous gonadotropins can be extended, and there can be more number of follicles which probably will be able to will be able to grow. And this period of FSH supply, which is given by the exogenous gonadotropins, is called as FSH window. Now we usually see, if we see this, now this is the window of FSH, of high FSH threshold, which we are extending in the ART cycles. That is what causes multifollicular recruitment in ART cycles. Now, so the rationale of ovarian stimulation in ART is to increase the number of follicles reaching pre-ovulatory stage by extension of this FSH window. And this is done by, as I already said, exogenous FSH administration or by anti-estrogenic agents, for example, clomiphene. They block the negative, they block the endogenous FSH, and that is how, if we are externally giving, uh, uh, they will promote the release of, they will help in extending the FSH window.
So,
Now I just
Sheetal, can I interrupt here?
Hanji, Hanji.
I just want to reinforce what you said. So, in other words, either the FSH window can be extended by increasing the dose of FSH also, because if you increase the dose, then more and more follicles can be recruited. But and also the duration of FSH window, that longer you give, then you can prevent the atresia. Am I right?
Yeah.
And but at the same time, there is an upper level also beyond which you cannot you cannot have unlimited number of follicles.
So I think, ma'am, yeah, this is right. So there is always, so if we have, usually, as I said, there are 2 to 10 follicles uh, per ovary, which are usually seen on the day 2 scan, and it is these follicles that is the maximum limit which we can stimulate, or which are available to us for stimulation. So this is how it is. And okay, so there is this interesting concept of luteofollicular transition. So we have to understand, if we look at this graph clearly. So in the mid-luteal phase, usually there is, with the decline in the with the declining regression of the corpus luteum, which usually starts in the mid-luteal phase, there is definitely a negative feedback, which is, and with the falling levels of inhibin A, again the FSH starts rising. And this rise in FSH starts in the mid-luteal phase. Now, this is something very important with aging ovaries, because with age, the quality of the corpus luteum and the quality of the follicle which is there, we all know that cycles shorten. Why they shorten? Because the regression of the corpus luteum, it starts early as the ovary advances. Now, this early corpus luteum regression leads to earlier rise of FSH, and that already starts in the mid-luteal phase, if we can see this graph. And this leads to early selection of the follicle, which happens premenstrually. So a lot of time in aging ovaries, on a day 2 scan, we can always we see a follicle, and then we cannot just stimulate this ovaries, because it becomes out of phase with rest of the antral follicles. And this sometimes in advanced age females leads to postponement of the IVF cycle. In such cases, premenstrual, in the previous cycle, we sometimes add estrogen, or we sometimes give GnRH antagonists. There are various ways, in which we can just prevent this premature FSH, premenstrual FSH rise, so that we get a synchronous group of follicles which we can stimulate. And this is something which is very important in advanced age females. Now, coming to the hormonal changes which occur in the menstrual cycle, if we all see that at the beginning, at the day 2 of menses, the E2 levels and the progesterone levels are very low. It is during this time, under the influence of FSH, the FSH rise, which starts already in the mid-luteal phase. This FSH rises. This green is the FSH. You all can see very clearly. This FSH rises. It releases estrogen, and this maximum FSH is usually seen till day 5, 6. And after that, the FSH receptors, the rising is follicular estradiol inhibits the hypothalamus and pituitary. And then after that, day 6 onwards, there is decrease in the FSH levels, and it continues to decrease till pre-ovulation, till the FSH peak which happens. It is during this time that FSH causes induction of LH receptors on the follicles. And after that, in spite of low FSH levels, LH receptors are the one which stimulate estrogen synthesis further in the follicle. And as a result of which, the follicle, even if there is low FSH to support, because of the induction of LH receptors, it is able to convert androgens to estrogens, and this is what causes an estrogenic environment, and this is the follicle which further continues to grow. Now, after that, by usually day 12 of the menstrual cycle, in the late follicular phase, once there is optimum growth of the follicle, these because of these LH receptors, this follicle has the very high estradiol level. Usually it goes beyond 200 picograms, and that is what this high estrogen induces the LH peak, and which gives us the LH surge. And before the LH peak, there is premature progesterone also which starts coming, which is caused by the luteinization of the granulosa cells. And this leads to this premature progesterone gives us an FSH peak, which just occurs before the LH peak. And this FSH peak further causes induction of the LH receptors, and then followed by which an LH surge occurs. And this LH surge is the one, it goes in an ovulatory cycle. If we see the LH levels, they go beyond 40 to 60 international units per liters, and which causes ovulation. And after that, once there is formation of corpus luteum, and that's how in the subsequent half post-ovulation, we see corpus luteum secretes copious amount of progesterone, and this progesterone is something which is the main hallmark of the luteal phase. And definitely this corpus luteum also produces some amount of estrogen, and that is why we do see, if we measure estradiol levels in the luteal phase, they will be somewhere in the range of 100, 120, 150. And this is something which is very unique to human ovary, that corpus luteum produces both estrogen and progesterone.
Ma'am, can I ask one very basic question?
Yeah.
Why do we start stimulation on day 1 to 2 of cycle? What is actually meant by the baseline scan? What do we see in the baseline? And why do we start stimulation for IVF in the day 1 or 2 of cycle?
I think this theory has also changed, yes. Sonal, but why we start on, because at that point in time, most of the hormonal levels are low, and at that time, we want to stimulate the follicles with the help of, that is the ideal time to start the stimulation. What is it that you are asking for? Maybe you can also answer what is it that you want to say or ask.
Yes, ma'am. Actually, you've already explained just for this thing, that FSH threshold and window, that is when the FSH starts to rise, and we can actually increase the threshold by giving exogenous FSH, and also increase the window so that more follicles are recruited.
I can add on to this question. I think this is a very important question. At that time, normally in normal cycles, even ovaries are at baseline, and all the follicles are at the antral stage, and selection of follicle has not started. The secondary recruitment has not started. So all the follicles are amenable to recruitment. So the follicles, if you stimulate at this stage, then there are chances of maximal stimulation. Once stimulation occurs, the other follicle, they start regressing. So you may be able to get only a discordant kind of cohort, or only a few follicles might just so the main purpose
I
of
think the
starting
aim
early
is
is to get
that normally it is only the dominant follicle, the follicle which is destined to ovulate is the one which will grow because it will have maximum number of FSH receptors, and there is only one follicle which is usually able to catch hold of that stimulus which is there, the rising FSH which is there at the beginning of the cycle. But but what happens is if we are giving exogenous gonadotropins, if you're giving
Ma'am, by the name of I, can you please mute yourself?
So, but if we give exogenous gonadotropins, we are enabling the other follicles also, which are there at the baseline scan, whatever enteral follicles we see. So all the follicles, they are able to, we are able to, we cross the FSH threshold for most of the follicles, and we are extending that FSH window so that all the follicles are above the threshold and they are propelled to grow under the exogenous hormonal, whatever exogenous hormones we are giving. Shall I move forward?
Yeah,
yes,
sure,
ma'am.
sure.
Yeah. So I think, so what are the main alterations which we are doing in an IVF cycle? It is multifollicular development. We are preventing the LH surge, and we are inducing ovulation, what we call very commonly, we use this term trigger. Now, this multifollicular development is something which I have tried to discuss. Now, what are the exogenous gonadotropins which we are giving? The exogenous gonadotropins which are available to us are in the form of recombinant hormones, recombinant FSH, and maybe we have some urinary preparations which are in the form of human menopausal gonadotropins. They come in highly purified form also, which have probably HCG-like activity, which gives us the LH activity in them. Usually they are started and we have recombinant LH, or we have those fixed dose combinations of these gonadotropins, which is pergoveris, which contains, which has FSH and LH in the ratio of 2:1. Now, these gonadotropins, as we just discussed, they are started in the early follicular phase when the endogenous FSH levels are rising. I'm sorry, this has to be rising here. And ultrasound is done on the baseline scan, which is done on day 2 to 3. We want to rule out if there is any cyst or any residual or there's any follicle which is developing, which I discussed in the beginning. And so on that, after that, if we feel that it's a synchronous cohort, then we give exogenous gonadotropins. And the first scan is usually done after 5 to 6 days of stimulation. And the main purpose of this scan on day 5 or 6 is to see the recruitment, whether in that by extending the FSH window, how many follicles we were able to recruit. So usually we on day 4 or on day 5 or 6 we measure the estradiol levels, and if it is less than 100 picograms on day 6, we feel that it is an inadequate follicular response, and more than 500 picograms per ml on day 5, it sometimes indicates hyperstimulation. And our aim is to, if we are happy as IVF specialists, if we are able to see 6 to 7 follicles per ovary, and total stimulation days, they can vary from 7 to 12 or maybe 13. Now, the second very important thing is prevention of LH surge. Now, if we, as I already said, multifollicular growth by exogenous gonadotropins, it leads to rising estradiol levels. Now, estrogen mid follicular phase E2 levels, high estradiol levels beyond 200 picograms per ml is the one which causes LH surge and initiates ovulatory changes, ovulation in a natural cycle. Now, once we have multiple follicles which are growing under the influence of exogenous hormones, then obviously the amount of estradiol which will be rising will be far greater. And that is why there is a risk of premature LH surge, and that is what we want to prevent, so that we can have more number of follicles which we can pick up once we are doing the ovum pickup. Now, in a natural cycle, the LH surge can start, and LH surge can be considered anytime beyond 10 milli-international units, 10 MIU per ml to 20 MIU per ml. And usually this LH surge is seen once the estradiol levels are beyond 150 to 200 picograms per ml. Now, if this LH surge is not prevented, it will lead to early rupture before ovum pickup. And there are two ways in which we can prevent this LH surge, which is by the use of by blocking the pituitary suppression with the help of GnRH hormones, gonadotropin, GnRH-A, gonadotropin releasing hormone, GnRH-A antagonist, which is commonly we use leupride or leuprolide or decapeptyl and all these. So these are the hormones which act on the pituitary, and they can help in blocking this LH surge. There are two methods of pituitary. One is we desensitize the pituitary by using GnRH agonist, and this is started in the mid-luteal phase of the previous cycle. I will just discuss about that in the next slide. And the second is we can add a GnRH antagonist. So in the late follicular phase, when we see that the follicles have reached approximately 13 to 14 millimeters, or we see that E2 levels are beyond 500 picogram per ml, we know naturally at this time LH surge can occur at these estradiol levels. So we start adding antagonist right in the mid, so that LH surge can be prevented. So now this is something which is, this is how GnRH, this is the upper one is the long agonist protocol, and the second one is the antagonist protocol. So now GnRH agonist, which is, I will just speak it as leupride. So what it is usually started in the previous cycle. Now, we all know gonadotropin releasing hormone, once it is released from the hypothalamus, it acts on the pituitary, and it is a positive hormone. It will initially cause rise in FSH and LH. So that is why it is started in the previous menstrual cycle. So in the long protocol, in the previous menstrual cycle, in the mid-luteal phase, once the corpus luteum is starting to regress, it is at that point in time GnRH agonist is started. And this GnRH agonist, because it has a positive effect on the pituitary, it initially leads to the rise of FSH and LH, and it is called as the flare-up response. Now, this flare-up response is initially because GnRH acts on the receptors on the pituitary, on the gonadotropes, and causes release of FSH and LH. Subsequently, if we continue to give this GnRH agonist, it causes internalization of the receptors on the gonadotropes, and subsequently then it leads to downregulation, and the FSH and the LH levels over time, it actually reaches almost the pituitary, the hormonal levels, they reach absolutely to the baseline. It is almost like a pseudo-menopausal state, which is achieved with the help of GnRH agonist. So usually it takes approximately this down regulation, which is done with GnRH agonist, it approximately takes 7 to 8 days for this down regulation to happen, which initially includes a flare-up response followed by down regulation. And once with the onset of menses, or maybe whenever you want, you can start the exogenous gonadotropins. And because now the hormonal levels, FSH and LH, have gone very low, now there is no question of LH surge which can arise in this long protocol. Now, if we talk of GnRH antagonist, GnRH antagonist, it is started now in the antagonist protocol. The FSH, usually the exogenous hormones, they are started from day 2 of the menses, and once the follicles reach 14 millimeters, 13 to 14 millimeters, or if the E2 levels are beyond 500, the antagonist is added. Usually the time when it is added is day 5 to day 7, depending on the ultrasound findings. And antagonist immediately causes, it works by competitive inhibition, and it blocks the GnRH receptors on the pituitary, leading to rapid decline in the LH, rapid decline in the hormonal levels. And then it is daily that this antagonist is administered along with exogenous gonadotropins. Now, so this is how I said that GnRH antagonist, it binds competitively to pituitary gland and prevents activation of endogenous GnRH. And then it blocks the FSH and LH release from the pituitary, and thus there is no rise in the LH surge can be prevented. Now, the big advantage of GnRH antagonist is that it acts very fast. The onset of action is very rapid, and it causes immediate suppression, and there is no flare-up effect which is seen, as with GnRH agonists. Now, I just wanted to bring to your note something very important which I wanted to share was the role of LH in ART cycles. Now, if I've been talking from the beginning that LH is required in the later half of the cycle. Now, if you understand this two-cell, two-gonadotropin theory, I'm sorry, I'm talking too much of theory, but this is very simple if we try to understand that oocyte is surrounded immediately by granulosa cells, and then in the stromal and outside the basement membrane, it is surrounded by theca cells. Now, what happens is in the beginning of the cycle, it is there are only FSH receptors which are present on the granulosa cell, and these FSH receptors help in the production of estradiol, which helps in the production of estrogen. But what happens is with the declining FSH levels, which occur usually by day 5 or day 6 of the menstrual cycle, there is these FSH receptors, they cause induction of LH receptors, and these LH receptors are present on the theca cells. Now, this is something which is very, very important. Declining FSH levels leads to decreased estradiol levels, but the LH receptors which are there, they cause production, they convert this androstenedione, which is there into, and this androstenedione is shifted to granulosa cell, and it increases the production of estradiol. So in spite of decreasing estradiol levels because of falling FSH, the LH which is secreted in the later half of the cycle, it acts on the theca cells and makes the environment of the follicle estrogenic. So which means the estrogen synthesis in the granulosa cells, it occurs in synergy with FSH by providing an androgen substrate, and this is the main role of the LH. So LH helps in promoting estrogen synthesis in the later half of the follicular phase. And this is something which is very, very important if we talk of this therapeutic LH window, which we ART specialists very frequently talk of, that there is some amount of LH which is required for the normal follicular growth and maturity. But how much is that basal LH level which is required? We are not very sure. Usually they say that if day 2 LH level is more than 1.2 and before trigger value is more than 1.5, this much is usually sufficient for the follicles to grow in an LH-rich environment and for the follicles to attain sufficient maturity. Now there are whatever gonadotropins.
Can I interrupt?
Yeah.
I just want to ask that what is you have already told the role of LH and LH surge in detail. Just very basic question that why do we need to block this LH surge in IVF cycle?
Otherwise,
you
it will rupture.
The protocol.
Otherwise,
yes, ma'am. Yes,
so if there is LH, if we are not blocking this LH surge, then it will lead to ovulation. It will just, all the follicles will rupture. So we don't want that. So once we don't want it, we have to block this LH surge. And this LH surge is blocked by the use of this GnRH analogs. Now here I am trying, what I'm trying to describe I hope I'm clear.
Yes, ma'am. Yes, ma'am.
Yeah, so now what I want to explain in this slide is that in the later half of the follicular phase, once we are giving this exogenous GnRH analogs to prevent LH surge, there is a theoretical chance that the LH, because GnRH analogs suppress both FSH and LH, there could be a relative deficiency of LH because of the addition of GnRH agonists. Now, that is why it is said that probably there is some role of adding LH in the later half of the ART cycles so that we are able to get good mature oocytes.
Let me add here, Shetil.
Hanji.
See, basically, what we have been trying to emphasize is that FSH is the main stimulator. But
Yes.
to get good mature follicles or good mature oocytes, you need both the hormones, FSH as well as LH. And LH is very important in the later half of the follicular phase to, give good estrogen levels and good maturity to the oocytes. And
Yeah,
both
and
cell
this is
to
some,
gonadotropin theory, it's a perfect. They work in perfect unison, and how they, mature the follicle in the natural cycle. And since we are trying to mimic it artificially, we also have to give both the hormones in the later half, especially.
yeah. So just to complete this discussion further, now once we are adding GnRH analogs to prevent LH surge, there is definitely a drop in the LH levels. Now, whether how much drop is there in the LH level is very, very individualistic. There are few patients in whom the LH levels will drop to quite a low level, and you might have to add LH from outside, or there would be few patients in which the LH levels are not dropping. So usually what they say is in most of the ART cycles, that is why most of the ART specialists, they probably switch over to different gonadotropins once they are adding GnRH analogs from day 5-6 onwards to for preventing LS surge. They might switch over to like either HMG or maybe LH derived preparations, maybe Pergoveris. But there are various studies which say that usually the drop in LH level is not that significant. So even if you continue with FSH only stimulation, there is this much amount of basal LH in the body, and it might not be affecting the pregnancy rates, and you might be getting similar number of mature oocytes even if you don't add LH. So, but in advanced maternal age or in women with poor ovarian reserve, yes, they say that addition of LH is definitely required because the quality of the eggs, the number of LH receptors in the aging oocytes is less. So you need to add LH in these type of patients. So now just to touch base the protocols, I already discussed the long agonist protocol, antagonist protocol, and in milder stimulation protocols, what we do is the aim is just to get 1 or 2 oocytes. So we usually add hormones from day 5 or day 7 of the cycle just to boost, and 150 international units of gonadotropins are added along with antagonist. And this is how milder stimulation protocols are carried out. And there is something which is called as short agonist protocol. I think I will not discuss it. Uh, it is beyond the scope, and these protocols definitely they need to be discussed in detail, and we'll be discussing in the subsequent series. Now there is this concept of premature progesterone rise, which occurs in most of the ART, which occurs in most of the uh, IVF cycles, and this is what most of the IVF experts are worried about these days. Now we have to understand that once LH is, once in a natural cycle, what happens is in the later half of the cycle, LH causes luteinization of the granulosa cells to produce progesterone. Now, most of the granulosa cells which are surrounding the oocyte, they get luteinized under the influence of LH and they produce progesterone. Now, progesterone is synthesized both by, we can see over here that progesterone is synthesized both by the theca cells as well as the granulosa cells. What happens is the progesterone produced by the granulosa cells, it moves to the theca cells where it is again converted to androgens, and these androgens they again travel back to granulosa cells and produce estrogens. Now, what happens in IVF is that there are more number of follicles which are being stimulated, meaning thereby there is more granulosa cell mass. Now, this increased granulosa cell mass due to multifollicular stimulation causes what it causes? It causes premature progesterone rise. So in the later half of the stimulation, once in IVF, there is a premature progesterone rise which occurs because of the increased granulosa cell mass due to multifollicular stimulation. And it is seen in as high as 2 to 35% of the ART cycles, it has been quoted in various studies. Now, what challenge occurs because of this premature progesterone rise? Progesterone is a luteal phase hormone. So now, if it is coming, uh, if it is rising prematurely, it definitely has its impact on the endometrium also, and it leads to endometrial advancement. Means endometrial advancement means that if we want to keep an embryo later on inside the uterus, if you're trying to keep a day 5 embryo, the endometrium might be of day 6 or day 7 maturity. So there is an embryo endometrial asynchrony which can occur because of this premature progesterone rise, and this definitely can affect the pregnancy rates, and this is what no ART specialist wants. Now, this is also said that out of the two protocols, agonist and antagonist protocols, this serum progesterone rise is more commonly seen with agonist protocols because agonist protocols have a more synchronous growth of the follicles, and that is why, because they have more number of follicles, they will have higher granulosa cell mass, and that will produce more amount of progesterone. Now, serum progesterone levels more than 1.5 nanogram per ml are considered detrimental, and but there are a lot of studies which say that you have to see E to progesterone ratio, and to date, whether this premature progesterone rise actually affects the ART cycle or not, it is a little controversy. Although literature is quite clear on it that it definitely leads to endometrial advancement. So a lot of ART specialists, they are checking this progesterone in the later half, usually just before the trigger, just before the trigger, to see how much progesterone rise is there. And in this scenario, they definitely do the pickup, make the embryos and freeze the embryos and do the embryo transfer later. And so this probably is what is called a segmentation of IVF cycle, that you stimulate, you freeze the embryos, but you transfer the embryos, you do an embryo transfer in the subsequent menstrual cycle. Now, the third step, which is something which is important, we have discussed about the extension of the FSH window. Then we have seen that how we have to prevent the LH surge in ART cycles. The third and the final and the most important thing is that the trigger. Now we have the follicles, we are giving exogenous gonadotropins, we have suppressed the LH surge. Now this causes ideal size of the follicles which we want to achieve is somewhere between 16 to 20 millimeters. This is what is the ideal follicular size which we want to achieve. So once we have achieved that follicular size, now because there is no natural LH surge which will happen, we have to trigger we have to mimic a natural LH surge so that we are able to take out, we can get the final oocyte maturation. So usually in agonist cycles, the only trigger which is available is HCG, and the doses can be from 5,000 to 10,000 international units. And this HCG is known to mimic LH activity. The difference is that HCG has a longer half-life than LH because we have blocked the LH surge. So we have to give something which mimics the natural LH, which is natural luteinizing hormone, and HCG very strongly, very closely mimics the natural LH. But it has a longer half-life than LH. It induces oocyte maturation almost as naturally as natural LH does, and definitely after that is able to provide adequate luteal support also. In GnRH antagonist, LH surge can be initiated by GnRH agonist, which is called as the decapeptyl trigger. Now, LH surge with agonist is shorter than the natural LH surge. This I'll be discussing subsequently. Now, if we talk of the triggers, natural versus HCG versus GnRH agonist, the main purpose of giving this, what does this trigger do? So once we have achieved full follicular maturity, we want this trigger induces the completes the meiosis 1 in the oocyte. Now, once we are giving this trigger, we are able to induce the meiosis, which is usually halted throughout the follicular phase. Now, the natural trigger, if we see the one which is in black, it has three limbs: the ascending limb, which is of 14 hours, the plateau, which is of 14 hours, and then there is the descending limb, which is of 20 hours. And it is usually in this descending limb that ovulation happens in the natural cycle. Now, what HCG is doing, HCG also has three limbs, but the only thing is the amount of HCG is almost 5 to 10 times potent than the natural LH surge, and the lutetropic activity of HCG stays for as long as 8 to 10 days, 7 to 10 days. If we talk of GnRH agonist also gives a very good LH peak, but its duration of action is only approximately to 20 to 24 hours. The surge initiated by GnRH antagonist is very small. So as a result of this, the luteal phase following GnRHA is defective. And this is why with GnRHA trigger, we have to lot of times freeze the embryos, or we might have to give extensive luteal support from outside, so in case we want to do a fresh transfer. Now, obviously, if we are triggering with an HCG, it is unphysiological. There are various reasons to it as to why it is. We are trying to mimic nature, but it is definitely not as natural as a natural LH surge which occurs. Now, what happens is, as I told you, that HCG is approximately 5 to 10 times potent than the natural LH. That is why the dose response HCG bolus causes a very rapid rise in the progesterone concentration, which leads to endometrial advancement. Now you can see in this first graph that natural LH surge is, I told you, to the peak of 40 to 60, but HCG, which mimics LH, and the dose response, the HCG levels are to the tune of approximately 140 international units per liter, which is very, very high. And this peak progesterone, and once after the trigger, what happens is the progesterone concentrations, they rise also very fast, and the progesterone which is secreted also comes 2 days earlier, and it is also very high as compared to the natural cycle. Now, this peak progesterone concentration, which is released by HCG, is also very high, and that is why what it causes is, it causes again endometrial advancement. And what we want is, we have to do once, if we want to do a blastocyst transfer after 5 days from the day of pickup, lot of females, they experience a drop in the progesterone levels after giving HCG, exactly at the time when we have to implant. So that is why sometimes after giving HCG, the peak progesterone levels which we want, in 20% of the females, the progesterone levels are usually are less. And that is why in such cases, this unphysiological triggering can lead to increased failures in case we are doing a fresh transfer. And why there is a defective luteal phase following the HCG trigger is because we have totally blocked the LH surge, and so there is no endogenous LH which can support corpus luteum. And this supraphysiological E2 levels which occur because of ART stimulation has a strong luteolytic effect on the corpus luteum. So that is why there is, in spite of such high secretion of progesterone by the HCG, there is an additional luteal phase support which we have to give in almost all ART cycles. So now this luteal phase support, in case we want to do a fresh transfer after giving the HCG trigger, we have to support it with progesterone because of the reasons which I told you, that there can be a defective luteal phase. Now, if we talk of GnRHA trigger, now GnRHA trigger is, as I told you, it quite mimics the natural trigger because it causes endogenous release of FSH and LH and gives us a good LH search, which is required for proper maturation of the oocytes. But the disadvantage is that it has shorter duration of action, and that is why the luteal phase is defective and luteal phase is short. Now, why GnRHA trigger is given? Because it has shorter duration of action. It causes extensive luteolysis by stopping the support of corpus luteum after 24 hours. It prevents ovarian hyperstimulation syndrome. So this is the biggest advantage with GnRHA trigger. Now, this trigger is definitely able to give us good oocytes, good M2 oocytes. The peak which it gives, the LH peak which GnRHA gives, is able to induce appropriate oocyte maturation, but is insufficient for supporting the corpus luteum, and that is why we need extensive luteal phase support in case we want to do a fresh transfer. So, because corpus luteum, embryo growth requires both estrogen and progesterone. So if we want to mimic the natural luteal phase support, we need to give both estrogen and progesterone in the luteal phase in case we have triggered with GnRHA trigger. And so this I have discussed already. And in case, a lot of times we are giving GnRHA trigger in PCO females because they have more number of follicles, and we cannot give them HCG because it predisposes them to the risk of ovarian hyperstimulation syndrome. So in those cases, we are usually giving a GnRHA trigger followed by freezing of all the embryos and just doing the IVF, just doing the embryo transfer in the subsequent cycles. So deficient luteal phase following GnRHA trigger.
We can skip this part and go to the segmentation, okay. I think.
Yeah, so in case we want to do a fresh transfer, we need a luteal phase following ART cycles in almost all. With HCG also, there is a luteal phase defect, and with GnRHA also, there is a luteal phase defect. And progesterone, which is the main component we all know is indispensable for successful implantation and pregnancy. Normal luteal phase LH levels are usually to the tune of 4 to 10. And in natural cycle, progesterone levels more than 10 suggest normally functioning corpus luteum. But with HCG trigger, there is supraphysiological rise of serum progesterone. I've already discussed this, and that is why a lot of times we are doing freeze-all in following HCG. And with GnRHA trigger, there is a deficient luteal phase, and sometimes there is decreased LH. There are deficient LH levels also. So luteal phase support is mandatory if the fresh transfer is to be done. And with and our aim is that we are able to at least give luteal progesterone levels more than 20 nanogram for adequate luteal support if we want a successful pregnancy. So usually luteal phase support is given in the form of 50 milligrams of intramuscular progesterone and maybe along with estradiol valproate in GnRHA agonist trigger cycles. So I think you want me to discuss something more in segmentation of IVF?
I think we can go for that.
So segmentation of IVF is done in case.
We can, I think we can skip now. We actually time is.
I think I'm almost at the end of my presentation, and I just wanted to.
Random start, you can say.
Yeah, maybe. So this random start stimulation is something, normally the classical stimulation, it begins in the early follicular phase, as I have discussed with you. The standard theory is that there is a cohort of ventral follicles which get recruited, as I discussed, during this luteofollicular transition. And out of this, one follicle gets to ovulate. But now there is a follicular wave theory which says that there is nothing which is called as that there is a cohort of follicles which is being selected, which predisposes, which gets exposed to FSH. Rather, there are multicolor follicular waves which occur over the menstrual cycle. So a follicular wave is defined as a synchronous growth of group of ventral follicles 2 to 5 millimeters in size that occurs at regular intervals during the menstrual cycle. It is not just that there is this, there is only one cohort of follicles which is usually which undergoes stimulation with FSH. Rather, there are a group of follicular, there are multiple follicular waves which are which are spanned over a menstrual cycle, and these follicular waves can be used at any time. You can start the stimulation anytime, and according to the wave of the patient, ultrasound a lot of times helps you. So a lot of times if you do scan in the luteal phase, you are able to see small follicles. So maybe that is a follicular wave which is there, and you can just stimulate those follicles with the use of exogenous gonadotropins. Obviously, there are definite protocols which are available, and uh, which can be used for stimulation. And these follicular wave theory allow us to take leverage of and maybe start the stimulation at any time in the menstrual cycle. So there are females which have two follicular waves usually, which is seen on day 1 and 14. And there are females in which approximately 30% in which there are three follicular waves, which are seen on 0, 12, and 18. And these follicular waves can be used to start stimulation in the late follicular or luteal phase. This was very important why this random start stimulation came, because it mainly came for cancer patients. Now these patients will quickly come to us and say, doctor, I have to undergo chemotherapy, radiotherapy, so if you can just preserve my oocytes. They will usually not have that much of time, and you can just do a scan, and if you're able to see good number of ventral follicles, maybe you can just start their stimulation then and there, and recruit as many follicles. As compared to standard stimulation, the number of follicles recruited are less. But yes, this is a very good scope, and it is now being tried in poor and normal responders also. In poor responders, maybe if the standard stimulation on day 2 is showing lesser number of ventral follicles, maybe you do a scan later in the cycle and see, and maybe if you're able to see more numbers, you can start random stimulation at that point in time. And definitely endometrium is out of phase in these, and so you have to freeze all in case you want to do a random start stimulation. So I think that was all. That was all which I wanted to say, and I'm open to questions.
I think another comment which I want to add would be the fragmentation of the cycle. And I think that's a very important part. Now we have practically separated the endometrial cycle from the ovarian cycle. So ovarian cycle we use for follicular recruitment and aspiration and obtaining the oocytes, and endometrial cycle we use for embryo transfer. So this endometrial cycle, it can be used from that cycle also, where we stimulate the ovaries, and fresh transfers can also be done if we think that the follicular development and endometrial receptivity, they are in unison. And but most of the times with premature ovarian rise, with hyperstimulation, there are opportunities more often than not that we cannot do a fresh transfer. So we nowadays, the success of frozen embryo transfer is as good. So we separate these two out. During stimulation cycle, we just concentrate on the stimulation and recruitment of the follicles, and in the transfer cycles we concentrate on the endometrium, and that has to be perfect for receiving the embryo. And that's how we manipulate the menstrual cycle to the advantage of the patient and to get the results in IVF. Any questions anybody would like to raise?
I don't know how much I was able to explain. Actually, there is lots. You can manipulate the menstrual cycle to any extent, and but
Thank you, ma'am, for the detailed and excellent presentation. You explained it really well and made the understanding very clear. And I would like
Right.
to have any questions from the participants. We would love to answer those.
So
Any
any question,
questions?
any random question which any one of you faces in your routine, in your clinical practice, or any doubts which you have related to ultrasound or anything, I'll be very happy to take up.
I think there are no questions, ma'am. So to
Okay.
conclude, can you give some practical tips for the doctors who are handling IVF cycles, keeping the manipulation of menstrual cycle in mind, just the basic ones, and then we can conclude.
I think one very important thing is that we all have to be very well versed with these basics. The common problems which uh, beginners face is that if there is a cyst formation on day 2 scan, now if we have to postpone, we have to postpone. And important thing is that uh, that ultrasound has to be, there is something which is called as whenever we are doing any ART procedure, we always have to remember, we just have to remember the natural cycle, natural menstrual cycle, how naturally ovulation is happening. And that is what is able to answer a lot of our questions. And just, I think we are totally doing segmentation of IVF in these days. So I think now the
Yes,
protocols
ma'am.
which are being used are antagonist protocols with, at least we are freezing most of the embryos. But yes, there is a scope for fresh transfer also. But you have to see, I think you have to be very selective in whom you're offering fresh transfer. And ultrasound has to be something, it is something which is called as sonoendocrinology. Your ultrasound is able to take care of, give you a lot of information about the endocrinology which is happening. And uh, additionally, you can take the help of the hormonal measurements which we do, throughout the menstrual cycle, throughout the ART cycle, which will just give us insights into the details. So I think this was very, very basic, which was you know as to, I just wanted to reiterate that three things which we are doing is we are just extending the FSH window above the threshold, above the FSH threshold. And then second is we are preventing the LH surge. How we are preventing it is through the use of GnRH analogs. And the third thing is the trigger. Now, as we are fine-tuning ART, we are realizing that yes, we are far away. We are mimicking natural physiology, but we are far away from it. So I think segmentation of IVF cycle is something which is a very big boon and which has drastically helped in improving the pregnancy rates.
Definitely, ma'am. So we thank all our participants for joining in, and we are looking forward for your presence in our upcoming clinical round series as well. So if any further questions we can take, I think so far there are no questions.
Okay.
So have a very good evening and have a nice day.
Yeah. Thank you. Thank you. Thank you, everyone. Thank you.